We'll just get started. Wonderful. Hello, good afternoon, and welcome to the Health and Government Operations Committee. Please do not forward the Zoom link for hearings. Staff will not allow anyone who is not invited to testify into the hearing. I ask that you encourage people to watch the hearing on YouTube. Bill sponsor witness timing information. The bill sponsor or their designee is allotted 5 minutes to present the bill. 5 witnesses will each be allowed to speak for 2 minutes in support. Please stay in the hearing until the delegates have had an opportunity to ask questions. After that, 5 witnesses will be allowed to speak for 2 minutes in opposition and then respond to questions. Please conclude your remarks when you see the timer finish. Members must remain present with your video camera on during the entirety of the hearing, and please only ask 1 question of the witness. If you have other questions, you may follow up offline. And of course, please use the raised hand function to indicate that you have a question. We just have a couple of bill hearings today, and first up is House Bill 207. Delegate Wilson, you may begin.
Thank you, Madam Chair. Madam Chairwoman, colleagues, I'm Delegate Wilson here to present House Bill 207. I try to be as brief as I can on this. Basically, this bill is a very simple bill. Sorry, my screen just jumped a little bit. It's to deal with the nursing homes. I think one of the things that our COVID crisis did, it exposed a lot of weaknesses we had in some of our facilities. And in Charles County, we took some devastating hits in our nursing homes. And even more devastating was a lot of the times the family members just were not made aware. This is when I say simple, it's probably one of the shortest bills I put in with, as far as amending, just putting a time period in which any member of or the family member who's on the list to be notified has to be notified within, I put in 24 hours, a certain period, because right now it's ambiguous. It just says that it requires that they notify a representative or an interested family member in the change of a condition, any adverse results of that condition, outcome, or unanticipated consequences. But as we found out during COVID, a lot of these family members were kept in the dark for days and days at a time. And some people found out as their parents were passing. It is a very simple bill. I do have an amendment in. I don't know if you received it, and I apologize, but the bill I put in required that they notify within 24 hours because I was trying to put a reasonable time. I've had multiple constituents ask me to change that to immediately. Unfortunately, immediately is not a clearly defined term because it depends on the set of circumstances. I did put this amendment in because I wanted to, this committee, and I know you're the subject matter experts on how best this could be implemented, to have some kind of input. But of course, as soon as possible is also too general. I thought about that's why I picked the 24 hours, because I didn't want to say as soon as possible. I wanted to give a definitive time, but I've had many constituents complain that even that's not enough time, 24 hours, it might be too late. And as you know, this is for, accidents involving the residents, which may be injurious or require physical intervention or physician's intervention, a significant change in a resident's physical, mental, or psychosocial status, or something that they need to alter their treatment. These are the things, as well as obviously the last one, transfer or discharge of the resident to another facility or a hospital. That's all I'm asking. For anybody who has grandparents, I'll be honest, I didn't grow up that way, but I've had a lot of constituents who expressed that devastation in not knowing what is going on with their relatives. We're only asking to be done for that person, that one single contact, but it be done at least within 24 hours. My amendment does have it immediately, but I will leave that to this esteemed committee's background knowledge to put in as you wish. And after that, I would just ask for a careful consideration and hopefully a favorable report on House Bill 207.
Thank you, Delegate Wilson. Do we have questions for Delegate Wilson from the committee? You can raise your hand in the raise hands function if so. I don't see any questions yet, but I did have one. So I haven't seen the amendment language, but we might settle on some language like as soon as possible, but at least within 24 hours, something like that.
Right, and that's what I'm saying. I just didn't want to leave it at, my initial goal was as soon as possible, but I know as a lawyer, that could be days.
Right.
But and immediate is great. It's also undefined, but that's also can be very difficult depending on the circumstances. So I'm definitely leaving that up to you guys. If you guys find this bill favorable, to set that time limit as you see fit. This is what you guys do. And I know I have faith in what you guys are going to put through.
Thank you. And we do have a question from Delegate Saab.
Thank you, Madam Chairman. So yeah, actually, Delegate, thank you so much for bringing this bill. That is an important bill, and I think we can work on some language. I'm not a lawyer, but I think we can maybe, to reiterate what the chairman mentioned, was that we can have like within, immediately or not to exceed a certain time. So if you want to keep the 24 hours or the 12 hours, whatever we think is reasonably a good reasonable time, maybe we can work on something that said that within reasonable time, not to exceed, 24 hours. Some sort of language. I think that would be beneficial to fix the problem there.
Thank you very much.
And a question from Delegate Bagnell.
Thank you, Madam Chair, and thank you for bringing this bill. I just wanted to clarify, looking at the testimony, if you can see it, Delegate Wilson, but in the testimony from Leading Age, they actually say that the federal regulations do say immediately inform the resident. So we may be able to pull language right from the testimony. And would that be your preference that we make this align with the federal regs if they already define immediately, though it is somewhat undefined?
Without a doubt. Again, I would just ask that because of my worry about what immediately means, you guys run it through your grinder to figure out if that's better, because honestly, I'm a lawyer. We get paid to play with words. So I just want to make sure that the intent of the bill is that the family be notified as soon as humanly possible when the situation allows.
Thank you, Madam Chair.
Wonderful. And seeing no more questions and no more people signed up to testify, that concludes the hearing on House Bill 207.
Thank you, Madam Chair.
We'll move to House Bill 554, Delegate Pena-Milnick. It's Division of Consumer Protection Assisted Living Programs.
Thank you, Madam Chairman and members of the committee. It is an honor to be here with you today. And I thank Senator Kelly, who asked me to put in this bill from an experience that she had with a couple of constituents in her district. So House Bill 554 will require assisted living programs. They have been appointed as representative payees for residents' Social Security benefits to file an annual report with the Consumer Protection Division. The representative payees will be required to report the use of Social Security benefits by the residents, as well as report on the use by the residents of other federal, state, or local funds. So basically report on the money that they get. Not all assisted living residents are the same. Facilities may range from a small home to a large facility. However, 72% of the facilities in Maryland are 9 beds and under. So this bill is a way to basically strengthen the oversight and protections for the most vulnerable in our community. I work with the AG's office, and actually they support the bill with amendments since they're the ones required to do some of this work. And the proposed amendments clarify the information to be reported and the referrals to be made by the Office of the Healthcare Quality to the Division of Consumer Protection in the Office of the Attorney General. And they also clarify the referrals to be made by the Office of Healthcare Quality to the Office of the Inspector General with the department. And I respectfully ask for a favorable report. Thank you so much for your time.
And do we have Tammy Brejnahan here?
Yes.
Wonderful. Go ahead.
Hi, good afternoon, members, Madam Chair, Delegate Kelly, and Delegate Pena-Milnick. Thank you for putting this bill in. It's good to see all of you, at least even virtually. My name is Tammy Brejnahan. I'm the Director of Advocacy for AARP Maryland. And you know, we're one of the largest membership organizations in the state, encompassing over 850,000 members. You have my written testimony. We are seriously, over the last couple of years, have been looking at assisted living, and I can validate Delegate Pena-Milnick's comments about Senator Kelly, because about 3 years ago, we staffed a caregivers task force, and this issue kept coming up over and over again. And so we know that people are very concerned about it. I just want you to know that AARP has looked at this. You'll see my written testimony about what the range, what they're supposed to do with Social Security benefits. AARP believes that government and long-term services and support long-term services and support providers can implement various approaches to promoting service quality and protecting the rights of consumers, which we think this bill does. And ARP believes that states should establish licensing requirements that set various standards and monitoring. We applaud the efforts of Delegate Pina Mielnik for bringing this bill forward to protect the Maryland's most vulnerable. ARP Maryland asked the committee for a favorable report. We thank you, and I am available for questions.
Wonderful. Do we have any questions for the proponents of this bill from the members of the committee? You can raise your hand in the raised hand feature. Looks like we don't have any questions. Delegate Pena Mielnik always ties her bills up together nicely. So thank you very much. With that, it concludes the hearing on this bill, and we will move on to House. Thank you. Move on to House Bill 599, which is my bill. So I will introduce it, and then Joan Smith will testify, and then we can move to questions. So this bill actually came to me last session at the end of session. It is one of the bills that it did not have a House sponsor on the House side, and we ran out of time. So we had not had time for a full hearing on this bill, but it was an important project. It was a project that was started by our former colleague, Delegate Morales. So she passed a piece of legislation in 2017 that established a task force on long-term care planning. And the recommendations from this task force, two of the best recommendations are in this piece of legislation. So Senator Klausmeier had it on the Senate side. It passed the Senate and came over to the House last year. We ran out of time to consider it because we hadn't had a full hearing on it in this House. So I agreed to put the bill in since Delegate Morales is not here anymore so that we could consider it. And it's really a very simple bill. It just implements the recommendations from this task force. Particularly recommendation 4 and 5 of the task force. It's going to require revamping and streamlining current long-term care information for Marylanders. Particularly, it would apply to all of the following: the Department of Aging, Department of Health, Department of Disabilities, and the Maryland Health Care Commission. It's really about getting information out there in an efficient way so that people can understand long-term care planning. And with that, I will pass it off to Joan Smith.
Good afternoon, Madam Chair, Madam Co-Chair, and members of the committee. My name is Joan Smith. As the committee may recall, Bryson Popham and I have represented our client, the National Association of Insurance and Financial Advisors of Maryland, for many years. I am here in support of House Bill 599 on behalf of NAIFA Maryland, and I thank you, Delegate Kelly, for introducing this important legislation. So you have heard about the task force created several years ago under Senator Feldman's legislation, and the implementation of these two task force recommendations, which are the substance of this bill. The consensus that the task force reached is that the state of Maryland should ensure that its citizens have broad access to important information about the need to plan for long-term care long before it is needed and how to do it. I can't honestly think of a more important principle of public health than government encouraging its citizens to think ahead to a time when, given the lengthening lifespans in our society, they need to provide for themselves when they no longer have income from their employment. I mean, it's a matter of personal responsibility. And this bill will provide impartial, unbiased, truly helpful information to those who recognize their personal responsibility. Now, Delegate Kelly observed that your committee often sees bills seeking to affect long-term care insurance cost, but this is not about long-term care insurance. It is about long-term care planning, period. And there's a difference. And I urge you to think about that difference. And finally, I wish to underscore and remind the committee that there is one change in the legislation between last year's bill and this year's bill. And that change is a modest delay in the effective date of the bill, which is accompanied by a modest delay in the implementation date. The purpose of that change is to recognize that the agencies affected by the passage of this legislation are knee-deep in pandemic-related tasks. And the change in the effective dates should help ease the burden during this tumultuous time. And I think my time is up, but it's been 4 years since we began this journey, and there is much more to do. But the passage of this legislation is a very important first step in providing useful tools for our citizens to begin thinking about this subject long before they need it. Again, Nathan Maryland respectfully urges a favorable report.
Thank you for your testimony. Do we have questions? I am seeing no questions. Thank you. Oh, I'm sorry. Does someone have a question?
I just said thank you.
All right, thank you. With that concludes the hearing on House Bill 599, and we will move to Delegate Stewart, which is House Bill 303, Long-Term Care Insurance, Prohibition on Premium Increases. Delegate Stewart.
Great timing, Madam Chair. I just entered the off the waiting room. Thank you all for having me. Good afternoon, everyone. For the record, I'm Delegate Vaughn Stewart. This is HB 303. So Groundhog Day is now over, but for the more tenured members of this committee, it will feel like deja vu all over again because you have a District 19 legislator in front of you talking about long-term care insurance yet again. However, for me individually, this is my HGO maiden voyage, actually, so I hope everyone is especially mean to me. As you know, thousands of Marylanders rely on and will rely on long-term care insurance to pay for things like nursing home care, assisted living, hospice care. Long-term care insurance generally covers what Medicare doesn't, and it fills a gap for those who are too poor to pay out of pocket, but too rich to qualify for Medicaid. About half of Marylanders will eventually develop a disability serious enough to require long-term care services. Unfortunately, the insurance industry made actuarial errors a couple of decades ago that have led to never-ending premium hikes for Marylanders who purchased their policies in the 1990s or in the early 2000s. The industry basically underestimated both the number of seniors who would hold on to their policies and how long policyholders would live. So, due to no fault of their own, seniors with these older policies are hit with premium increases nearly every year, often up to Maryland's 15% regulatory cap. Seniors have cut back on groceries and prescriptions to afford these rate hikes, which often total several hundred of additional dollars per year. So an example of, we heard from a senior in my district whose annual premiums increased from about $3,000 a year to about $5,000 a year in about 5 years' time. HB 303 provides a simple and modest solution to this big issue. The bill would prohibit long-term care insurance premium increases for Marylanders aged 85 and older if they have held their policies for at least 10 years. This change would provide predictability and certainty for seniors during their most vulnerable years. And I'll note that we submitted a sponsor amendment to clarify that we're looking merely retrospectively rather than prospectively. And as I mentioned at the jump, the idea of providing seniors with premium relief is not new. Now Senator Kramer and then Senator Mano have introduced legislation to, for example, halt premium increases altogether or limit them for individuals aged 80 and older. I have narrowly targeted this bill to those 85 and older who have had their policy for a decade in an attempt to respond to past industry objections. And I know that, despite this narrow targeting, I think you're probably about to hear from Mr. Celentano, and he'll warn that the bill will cause undue hardship for the insurance industry. And I understand that many insurers only break even on these LTC products, though they do, it's worth noting, provide other more profitable products. No one, including me, wants to bankrupt insurers or make it impossible for them to pay out benefits. But at the same time, it's important to remember that these companies are national. So when premium rate increases are rejected in one state, those costs are passed on to policyholders in another state. So when we greenlight premium hike after premium hike here in Maryland, our seniors are subsidizing seniors in other states that blocked similar hikes. All of that said, I'm open. I'm absolutely open to any additional amendments that the industry wants to posit to even more narrowly target this bill. For example, if they think that we should increase the amount of time seniors have to hold on to the plan before they're eligible for relief, I'm open to all of that because at the end of the day, many seniors in Maryland are paying year after year for the industry's bad math. They just want a little bit of relief. And they did the responsible thing. They did everything right. They bought policies in their 50s and 60s when everyone says you should, when premiums are lowest. But now those responsible middle-aged Marylanders are senior-aged Marylanders, and they desperately want some certainty that once they reach a certain age, their premiums will be locked in. So I urge a favorable report.
Thank you, Delegate Stewart. We have a couple of questions. We'll start with Delegate Kipke.
Thank you, Madam Chairman. I don't have the sign-up list, so if the Maryland Insurance Administration is signed up, we can defer to them. But if they're not signed up, I'd just like to know if Delegate Stewart, if you collaborated with the Maryland Insurance Administration.
I did. I spoke with them, and they actually are the ones who brought the amendment to my attention. And they told me that they may or may not be testifying as informational. They weren't going to take a position, and didn't seem my conversation with them to feel strongly either way about the bill. So I guess they decided not to testify at all. But I did work with them on the bill and on the amendment.
Thank you.
And yeah, we do not have them signed up at all. Delegate Kipke's question was answered, and I thought Delegate Bagnall had a question, but I guess her hand went down. Is that right, Delegate?
My question was answered.
Perfect. Wonderful. Any further? It looks like Chairman Pendergrass has a question. And she's still on mute.
I'm going to be the bad guy here. I noticed that Delegate Kipke didn't go all the way to being the bad guy.
I only get one question.
My bad. Okay. So what we've heard in past years, Delegate Stewart, from the Insurance Administration, usually in a briefing, but I think on this bill as well in general, but the briefing was on long-term care. And the insurance companies did make mistakes in the beginning by expecting the cost to be lower to them to pay off the benefits over the long term. The problem and the wonderful thing is that people are living longer, so they are paying more than they expected to pay. So they changed their assumptions on later policies. But on these policies, the concern is that I don't know that the risk is spread over other states. I do know that they have to meet certain fiscal guidelines to make sure that they can pay out, because if they pay too much and don't take enough in, then the people who have policies will get nothing paid out. They'll be, go out of business. So then other people have to take over and use the pool that there is. It makes a big mess. So did you have that conversation with the Insurance Administration about what impact, even with the amendment, this would have on their fiscal solidity? Is the wrong word, but there is a word. I can't think of it.
Yes. So all that is exactly on point, and I absolutely welcome you, Madam Chair, being the bad guy or gal. As I said, I hope that you guys are mean to me for my first appearance here. I did speak with them about that, and I don't want to sort of misquote them or anything, but I'll just be candid with exactly what the conversation was. They said, you're going to, it sounds like what you're more focused on here is retrospective instead of prospective. I said, that's correct. They said, well, we could read the bill either way, so that's why you should submit a sponsor amendment. I said, great, thanks for the heads up. They then said that, basically that this was, they seem to imply that basically this was narrowly targeted enough that while the industry may have concerns about exactly what you mentioned, that they won't have enough money to pay out, it did not seem like the administration had any concerns, which is, I suppose, why they didn't come. But that said, I don't want to misquote them. It's possible that they have concerns they didn't share with me. The one concern they did bring up with me that they said that the industry may bring up is the contract clause of the United States Constitution, of all things. It brings back some heavy PTSD for me from law school, but basically it prohibits state governments in certain cases from interfering with existing contracts. So I did some research into that. I'm happy to share some of my kind of written research into that with the committee if it's helpful, if that's a hang up for everyone. I do not think the contract clause would apply to this bill. I'm also happy to submit an AG letter, which I have not done, but that was the only real criticism or objection that the agency had, the MIA had.
I think it would be to have when they deliberate the bill.
Sorry, Madam Chair, you cut out a little bit for me. It could just have been on my end.
I think it would be helpful if you got that information to the committee so that they have it for the subcommittee deliberations. Thank you for offering.
I would love to. Thank you, Madam Chair.
All right, and I don't see any more questions for the bill sponsor. We do have a panel in opposition, not a Dr. Matt Chellen.
Delegate Krebs has a question.
Delegate Krebs, thank you, Delegate Bandari. Delegate Krebs.
It's just a quick question. You keep saying retrospective and prospective. So am I getting confused? This is prospective. Anyone currently that buys a policy that will be moving forward. So is it prospective or retrospective?
It's retrospective. Thank you for the opportunity for clarifying. I recognize those terms are probably not super clear in this context. So what the MIA said is, prospective would mean that anyone who signs up from a policy henceforth, once they turn 85, so they sign up for a policy, on October 2nd after the bill comes into effect, once they hit 85, they can no longer get a premium increase. That would be prospective. That's not what we're doing, however. What we're saying is that for people who have already had policies dating back a decade or more, so, way in the past, where I'm trying to obviously target this population that, as the chairwoman said, has been hit the hardest before the industry started to correct their mathematical errors. For only that population, if you've had a policy for longer than 10 years in the past, previous to our passage of the legislation, and you turn 85, you will no longer see premium hikes.
I think the opposite. I think that's going to be the problematic piece because they already entered into their contract. But and then for the sake of the amortization from the insurance companies, they won't be able to calculate that in. If it's prospective, they can sort of put that into their rate base. But I let the opponents discuss that. But thank you for explaining that.
Yeah, thank you.
Okay, wonderful. Thank you, Delegate Stewart. Moving on to the opposition, Matt Celentano.
Good afternoon, Madam Chair, members of the HGO Committee. My name is Matt Celentano. I'm here today on behalf of the League of Life and Health Insurers of Maryland, America's Health Insurance Plans, and the American Council of Life Insurers in opposition to House Bill 303. We totally understand why this bill was introduced. Long-term care is expensive, and a lot of reasons are because of miscalculations that the insurance industry made, especially on the legacy book of business, is how long-term care sort of started. These were policies that were written by the industry that had unlimited benefits. When these original policies were written, the cost of care of an annual nursing home was roughly in the area of about $20,000 a year, with unlimited benefits and the cost of that care skyrocketing to over $100,000 a year. The insurance industry just messed up. There's no other way to put it. We flatly did not price the policies correctly. Folks are also living a lot longer than we thought they would. The industry just dropped the ball. There's no other way to put it on pricing these products, and it's having lingering impacts on the marketplace. But House Bill 303 is the wrong direction and could threaten the solvency of a lot of these long-term care companies that are trying to continue to pay out benefits for folks that need their long-term care. As you have heard before, Maryland has a 15% rate cap hike on long-term care policies, which is the lowest in the entire country. This committee passed House Bill 946 2 years ago, the contingent benefit upon lapse, which would let you draw down from what you had already paid in. If you could no longer pay your policy, Maryland became a state where you could start drawing down to pay your claims if you no longer could afford it. That was a big step. The Maryland Insurance Administration has robust rate review to make sure that we have actuarially sound companies. And last year, this committee took a really big step to pass the guarantee fund revisions to make sure that in the event of an insolvency, which is what we're talking about here, Marylanders would be made whole. If you pass House Bill 303, we threaten to take the guarantee fund out for a test drive. Nobody wants to do that. We respectfully ask for your opposition to this bill, House Bill 303.
Thank you. Do we have any questions from the committee? Giving you a second. I'm seeing none. So thank you. And with that, we're concluding the hearing on House Bill 303. Moving on to Delegate Shetty's bill, House Bill 429. This is the last bill of the day. Pharmacists required notification and authorized substitution, lower cost drugs or device product. Delegate Shetty.
Hey, good afternoon, everybody. Thank you so much. I really appreciate the opportunity. For the record, Delegate Emily Shetty to present HB 429, which will help lower the out-of-pocket costs for that patients spend on their prescription drugs, reduce prescription drug abandonment, and help patients adhere to their treatment plans. This bill is a reintroduction of a bill from last session, HB 1119, that passed this committee and the House unanimously, but ran out of time. The version before you today is identical to the amended version passed. The current law in Maryland, as you know, notes that unless a prescription is noted dispense as prescribed or dispense as written, pharmacists can substitute a therapeutically equivalent generic drug for a brand name drug. What HB 429 will allow is it will require pharmacists to notify patients of the lowest cost therapeutic equivalent drug, and it would authorize a pharmacist to substitute a lower cost therapeutic equivalent drug without requiring a new prescription from the prescriber. Increased out-of-pocket costs are a big driving factor for prescription drug abandonment and hospitalization. Patients spend on average $1,200 per person on medications per year. As of 2018, nearly half of consumers have abandoned a prescription due to costs. Non-adherence results in 125,000 preventable deaths every year and $300 $300 billion in additional healthcare costs. Giving patients options of the lowest cost therapeutic equivalent drugs will reduce prescription drug abandonment and lower overall costs on the system. So last session, I worked with pharmacists, patient groups, payers, retail pharmacies, pharma, and prescribers to ensure that all of their concerns with this bill introduced were addressed. The version that's before you today had either the support or neutral position of each group once the amendments were adopted by this committee, and you'll see many of their statements in support are in the bill file before you today. I know MedChi met and were able to get a statement in support as well, but I don't know that it's been included in your bill file. It might have missed the deadline. The version is entirely unchanged since then. The only thing that has changed is that more and more of our constituents are struggling financially due to the pandemic, and ensuring that they have access to the lowest cost medications available to them could truly assist them and their families. I respectfully request a favorable report of HB 429. Thank you.
Thank you, Delegate Shetty. Did you have a panel signed up, or do you want to take questions yourself? I have Kaylee Locklear also signed up favorable, and Allison Taylor favorable with amendments. So I just hopped over from Judiciary, where they are hearing the jointly referred bill, and I know Allison was testifying there while like as soon as I left there, and I texted Kaylee to let her know that we were up. I don't know if she's in the waiting room or not. She texted me back a thumbs up. So I'm not sure.
They both should be in the Zoom room.
Okay, so should we hear from them and then help do questions after that? Okay, wonderful. So let's hear from Kaylee Locklear.
Good afternoon, honorable members of the committee. For the record, Kaylee Locklear here on behalf of the Maryland Chain Drugstore Association, and we are here in support of this bill. I want to commend the sponsor and the committee for passing this bill last year. There are a lot of stakeholders involved. This bill is a couple of years in the making, and we as an industry are supportive of consumers obtaining the lowest cost drugs. A couple of things have come up that I'm here to address, and I'm glad to answer any questions the committee has. I believe you all have an Attorney General letter that we're thinking may be actually based off of last year's bill. And I just want to reiterate to the committee that brand to brand was removed from the bill when you passed it last year, and that's the bill that you have before you. I am glad to discuss in more detail therapeutic equivalents, but contrary to what is written in that letter, there are absolutely FDA recognized equivalents for generic to brand, brand to generic, and generic to generic drugs. I know Allison's going to talk about Kaiser, and they have an amendment. I just wanted to mention that their amendment is fine for their operations, but is actually not for ours. So the way I think that the committee, we could address that would be to just change language on page 3 to add what they're looking for, which is maintain a record. And I'll let them speak to that, but I can go into more detail if you all would like. And then the last thing I just wanted to mention that came up is I know the Board of Pharmacy sent you all a letter. And we believe that that issue can easily be rectified with a small additional language change. And I know that the sponsor has been working with the stakeholders on that too. So I'll stop there. Glad to answer any questions the committee has, and we urge a favorable report.
Thank you. And let's hear from Allison Taylor, and then we'll move to questions. Allison?
Good afternoon, Madam Chair, members of the committee. For the record, my name is Allison Taylor. I'm here on behalf of Kaiser Permanente. We are in support of the bill. We supported it last year as well. With fresh eyes looking at it this year, we did have a small proposed amendment that Kaylee referenced a minute ago, related to a record-keeping requirement. Happy to discuss that with stakeholders, but we do see that as a friendly amendment. I hope it would be perceived as such. Anyway, I want to thank the sponsor for her leadership on this and other prescription drug-related issues, and we urge a favorable report.
Thank you. We have a couple of questions. Delegate Morgan.
Thank you, Madam Chairman. How are you? Delegate, thanks for bringing this bill forward. I just had a question. I'm reading the bill. It looks like you're swapping a generic for a brand drug, but what happens if the brand drug was actually cheaper?
That's a great question, Delegate. Thank you so much. So right now, under current law, pharmacists can substitute a therapeutically equivalent generic drug for a brand drug if it's cheaper. But what this bill does is, if in the event that the brand drug is actually cheaper, it would allow the pharmacist to make the same type of swap that they're currently allowed to do going from brand to generic. So equivalence works both ways. The FDA has a large database called the Orange Book that pharmacists use to define what is a therapeutic equivalent drug. And they would use that same book, to that same database, to essentially determine, okay, these two are able to be swapped. In this instance, as you've referenced, the brand drug is cheaper. It would allow the pharmacist to make that swap without having to go back for an additional prescription from the provider.
One more question, Madam Chair. What happens if a physician expressly named a drug?
Yeah, that's a great question. So under existing Maryland law, a physician can expressly name a drug, but in the event that there are different therapeutic equivalent is cheaper, they say the name brand drug is named, but there's a cheaper therapeutic equivalent generic. If the physician doesn't specifically write dispense as written or dispense as prescribed, then that swap can be made under current law. That's already existing law. And what this bill does, it expands that authority to basically recognize that equivalence goes both ways. So, but it's still preserving the prescriber's role in noting, if the prescriber says, there's an inactive ingredient in this drug that I'm really worried about, or in a therapeutic equivalent that I'm worried about, so I really want you to take this brand drug, or I really want you to take this specific generic drug, they can still do that. That existing authority that prescribers have is still preserved in this bill. So a prescriber, a doctor, can say, I really want you to take this drug, don't get a substitute, I'm just going to write on this prescription, dispense as prescribed. And that preserves that role that prescriber has.
Okay, well, I appreciate you answering the question. Thank you.
Thank you, Delegate.
We have a question from Delegate Saab.
Thank you, Madam Chairman, and thank you, Delegate, for bringing this bill. I think we all advocate for lower out-of-pocket costs, but I have a couple questions. One of them is cheaper to who? Is it cheaper to the insurance company, or is it going to put money in the patient's pocket? And the other question I have is it cheaper with coupon or rebate? I know the bill doesn't specify that, but when you say cheaper or lower or lowest, what is exactly we talking here about?
So I can take that. Thank you for the question, Delegate. So under the bill, the definition is based on, there's sort of two components. One is if the patient is uninsured, then it's just cheaper out-of-pocket cost, right? And the second component is if the patient is insured, then it's based on the patient's formulary. So it's the out-of-pocket cost still, based on the patient's formulary. And I don't believe we have a specific reference to whether coupons can or can't be used.
Okay, and when you say, like, when you in the bill it says lowest, not lower. So do they have to go specifically and look for the cheapest, the lowest brand to substitute, or they can substitute in between? If you say lower, I think you have a little bit more flexibility that gives them to use which generic. But if you put the lowest, does that mean they have to go specifically to the very least expensive one and choose it? And are they required to do that? This bill will require them to do that.
This bill is may, not shall substitute. They may substitute for the lowest cost option that's available to them. So the idea being that if there are, you know, 7 different alternative options that they have to notify, the lowest cost language is around the notification component. So it's notifying the patient of the delta between the lowest cost option and the existing prescribed option. So so this is really more of like trying to address like potential workflow challenges that pharmacies could have if, like, say there are 10 options on the table. Then looking at the lowest cost option would allow them to give patients the information that they seek, which is what's my cheapest one.
Thank you.
Instead of like, these are 10 options and these are all of the prices.
Thank you.
Yes.
All right, it looks like that is our last question. I'm just going to make sure Delegate Bhandari has a question. So close. Delegate Bhandari.
Yeah, thank you. This is an excellent bill. I'm wondering the implementation side of the bill in the light that the FDA has not determined any of the therapeutic equivalence of the brand drugs that would be substituted for one another without the prescriber authorization. Is AG letter mentioned as well?
Thank you, Delegate Bhandari. Kaylee, do you want to take that?
Yeah, I'll go ahead and take this. So this is what I alluded to in my testimony. This bill does not deal with brand to brand substitutions, and that's where that problem comes into play. But the FDA absolutely does designate generic therapeutically equivalent drugs to brand drugs. And that goes both ways, as the delegate was just talking about. For something to be a therapeutic equivalent and that substitution to be made, the drug that's substituted has to have the same clinical effect, the same safety profile. It has to contain the same active ingredient, dosage form, route of administration, strength. The FDA has to assign that therapeutic equivalent a code. There's a whole subset of criteria that must be met. And I think what the AG might be referencing in their letter is brand to brand, because that's where you come into contact with drugs that there are not therapeutic equivalents. But for generic to brand or brand to generic, yes, there are.
Thank you. And is it possible that
you can have one follow-up because I allowed it for the others, but I want to remind the committee of the rule: 1 question, 1 answer.
Yeah, just it would be wonderful for the committee if you could clarify that clarification with the AG office, and they could write and we could feel more comfortable.
So if I can answer that, I did actually, when I saw the AG's response, reach out to the FDA to get an official response from them, detailing exactly how the implementation efforts could work. We do believe that the AG, respectfully, I would say that the AG's letter is based on the introduced bill from last year, which would have allowed brand to brand substitutions, which is where I think some of the miscommunication might be. And so I will provide, once I receive the definitive letter from the FDA explaining this, I'll provide that to the committee as a resource as well.
Thank you.
Thank you.
Thank you to the panel. That's it for questions on this bill, and there is no opposition panel. So that concludes the hearing on House Bill 429, and the work